Welcome to Going Antiviral, the podcast for the IAS-USA, a professional continuing medical education organization focused on HIV and other viral diseases. I'm Dr. Michael Sagg, professor of medicine and infectious diseases at the University of Alabama at Birmingham and volunteer member of the IAS-USA Board of Directors. In this episode of Going Antiviral, we represent a panel discussion as part of the dialogue series Latest Update on Urgent Viral Outbreaks, sponsored by the IAS-USA, presented on October 4th, 2024. The panel was moderated by Dr. Carlos del Rio from Emory University, and the panelists included Dr. Yvonne Maldonado from Stanford University and Dr. Peter Chin-Hong from University of California, San Francisco, and Dr. Paul Sax from Brigham and Women's Hospital in Boston. All of the panelists are experts in viral diseases, epidemiology, and treatment. And with that introduction, let's begin.
Well, good afternoon, everybody. I want to welcome you on behalf of the International Society USA. My name is Carlos del Rio, and I'll be moderating today a discussion with three colleagues and friends talking about the latest update on urgent virus outbreaks. And this is as of today, October 4th, 2024. And there's a lot to talk about. Joining us today are Dr. Yvonne Maldonado from Stanford University. Bonnie is a pediatrician, vaccinologist, and somebody who has been working in many viral diseases. She is a member of the ACIP, and she has a lot of experience dealing with viral infections. We also have Dr. Peter Chin-Hong, who have you seen previously. Peter is at the University of California in San Francisco, and he has really been a leader not only in HIV, but during COVID, really being an excellent communicator and somebody who you're familiar with. And we're really pleased to have Dr. Paul Sax join us today. Paul is at the Brigham and Women's Hospital, where he is the director of the HIV program, but also for all of us, what Paul is his daytime job is also to be the editor-in-chief of Clinical Infectious Disease, which is really the journal of the IDSA, and really a very important journal that provides a lot of updated clinical information and groundbreaking information on viral infections. Paul also writes a blog that if you're not subscribed to, you've been missing a lot of not only good information, but a lot of fun and trivia around baseball and many other issues. So this is I think we all, COVID pandemic is over, but we continue to talk about COVID, we continue to talk about influenza and RSV, but we're also in this strange time that we have H5N1 popping up in cows and dairy workers, and some individuals who are not dairy workers who are getting infected. We also have, mpox. We had an mpox outbreak in 2022, primarily among MSMs, and we talked about that. But now we have an mpox outbreak occurring in the DRC, which is not among MSMs. It's primarily affecting women and children. It's a different clade. And we have some recent data from a clinical trial that TPOXX or tecovirimat really doesn't work. And the question is, does vaccination work? What are we doing about it? Do we need to worry? And in the past couple of days, we've heard about a new outbreak, an outbreak of Marburg occurring in Rwanda. So it almost feels like a lot of fires are happening at the same time. And those of us in ID continue to worry about them. So I think it's a unique opportunity to update our audience about where things are, so we can tackle each one of these on a sort of sequential basis. But why don't we start talking about the respiratory viruses? We are entering the fall, and where are we? Do we get vaccinated against the flu? Yesterday we saw an MMWR that said, maybe the vaccine is going to be 30% effective. Is that good enough to get vaccinated? We have COVID vaccines, we have RSV. So what do we tell our patients? So Bonnie, why don't we start with you?
Yeah, I think the CDC, continues to try to message around all of these pathogens, and their approach is kind of a respiratory season messaging. That is, let's talk about COVID, flu, and RSV together. We know that the burden of disease from all three is still pretty remarkable. I mean, people are still hospitalized and dying from COVID. I had one of my colleagues at Stanford, who's a chair, say that one of her best friends just died from COVID last week. It's not gone. And as a pediatrician, I'm used to very rare event, that we vaccinate for reasonably rare events, because we know that if we can avoid these terrible outcomes, we should do it. And I think COVID really put us in a place where we think, well, if millions of people aren't dying, why should I get vaccinated? And the point is that we want to keep it that way. And this idea of herd immunity kind of just went right out the window. So I think flu, 35% effective. If you look at the data going back to 2000, effectiveness ranged from 10 to 70% on a given year. And as Kathy Newsel said once, and apologies to you, Kathy, I always take your quote. It's not about half glass empty, half glass full. It's about how big the glass is. And this is a very big glass. So when you have tens of thousands of people dying just in the US alone, it is worthwhile to think about a 35% reduction in risk of infection and potentially even death and hospitalization and death. Similar for RSV, we have really great data now for this really remarkable vaccine that, by the way, I have no interest in the adult vaccine, but we saw, 80% plus effectiveness. And primarily, ACIP recommended this coming year to make it easier to recommend to everyone 75 and older. It's very clear that that's the highest risk group for hospitalization, ICU, and death. And the vaccine is very effective. Now, for 60 to 75-year-olds, the idea is really there to just leave it up to not shared clinical decision-making, but to provide it for people who have underlying conditions. Because in that situation, 60 to 75-year-olds, the risk is highest for those with underlying conditions for hospitalization and death. And so I think it's been more streamlined. And then finally, of course, COVID continues to be an issue. We're worried about, we can talk about this more. We don't really have a seasonality yet, so we have to continue to be worried about when the next surge will happen. So we continue to recommend all three. If you want to go to cdc.gov, they have some really nice, simple messaging that people can do if you're working on the front lines. I just put together a little slide set myself. Simple messaging from practitioners. Rather than asking, do you want the vaccine? You say, it's time. Here's the vaccines. Let's just go ahead and do it. And, having people opt out rather than opt in actually always works best.
So Paul, thank you, Bonnie. That's great. Paul, it's interesting. We have now the CDC saying, the vaccine, the RSV vaccine is strongly recommended for everybody 75 and older, and maybe it's a decision maker of those 60 and older. But that's very different from what they're telling us about COVID vaccine. COVID vaccine, they're saying everybody over the age of 6 months should take it. And what do you think? I mean, should we just limit the vaccine as a must take for those 65 and older, which are the highest risk of death?
Well, as you and I have discussed previously, I feel like we have a real data gap in COVID effectiveness after the first wave came through, after the first vaccines, and now that over 95% of Americans have had COVID. So there's a great deal of residual immunity. It may not be sterilizing immunity, but it is protective against severe disease. And to have a broad recommendation for COVID vaccines for young, healthy adults and for children without a current contemporary clinical trial comparing it to placebo is in my view, a very big statement to make, and one that I think I know that I'm married to a pediatrician. I know that this is something that her patients bring up all the time, and I have young and healthy, fortunately healthy adult children, and they want to know, should they get the vaccine? And I say, get it if you want it, but I can't tell you, guarantee that it's really going to help you that much. I still do strongly recommend it for older adults and for people with comorbidities. But I think we also should remember that these are vaccines that are quite reactogenic, especially the mRNA vaccines, and there are some adverse effects that happen, in particular in younger males. So, I'm hopeful that one day there will be such a study, that there's a seasonal study, even though it's not there is transmission year round. I completely agree with what Bonnie said, but there are definitely increases that happen around the fall and winter that we've seen now every single year. And you could do a placebo-controlled trial in healthy young adults comparing a COVID vaccine to no COVID vaccine with an endpoint of severe illness as a primary endpoint and an endpoint of infection as another endpoint. And I think that would be very valuable and help inform our patients to make the best decision for themselves.
So can I just say, Paul, I agree with that. And one of the issues that I think ACIP faces is in the absence of that information, it's really hard to do risk-based recommendations. You saw what happened with RSV last year. Nobody likes shared clinical decision-making. We as pediatricians can't stand it, honestly. And so I think the decision was, give a broad-based statement because there's, as you said, there's no data. But it's also important to recognize that of the hospitalizations, kids under 6 months of age who aren't recommended for vaccination are the second highest risk group for hospitalization after 75 and older. So it's the message there is difficult to make because those kids may not be protected directly, and so indirect immunity is one way to provide that. But again, universal recommendations are just easier. It may not be the most evidence-based, but we do need that data. I agree.
Yeah, European countries have not followed suit. They have a different approach.
Kind of give 2 points regarding that issue. The first is that, I agree with all the pros and cons to Bonnie. And Bonnie, correct me if I'm wrong, but I think there were about 200 kids who died last year from COVID. And interestingly, 80% were unvaccinated who were eligible for vaccination. So again, it's a risk-benefit issue and what it means to society in the absence of data, like you said. And in a cost-constrained society, it may be different versus others. And I guess the second point is what Bonnie was saying about the ability for us to really risk stratify on a societal basis. I think there's some evidence. I think flu vaccine was risk-based before, and we didn't do very well. We're still not doing great, but it's just easier. And some people argue that it may be more easier for people without access to who may not perceive themselves at risk to think about it in that setting. But again, I see the pros and cons.
So Peter, let me stick with you on asking about a related question, which is, tell us about this new monoclonal antibody at PEMGARDA that recently received FDA approval for prevention of COVID in high-risk populations. When are you using it? How are you using it?
Well, I think it's where we have the infrastructure set up. I think it's very clunky to set up because you need at least more than 2 hours. You need an hour infusion, hour of observation. I think this idea of who's at risk is kind of changing in the immune compromised population. What we've realized is that not everybody is super immunocompromised who might benefit from it. Sure, if you have multiple myeloma, if you're on a B cell depleting agent and you can't make antibodies, it probably is the lowest hanging fruit. But I would say the devil is always in the details. And while it sounds really great conceptually, I think operationally it's been a bear. First, identify patients who might benefit the most. Because even in medium immune, 5 out of 10 immune compromised states, people are having antibody responses, and you also have other tricks up the sleeve. Although with Paxlovid, you have drug-drug interactions, particularly with calcineurin inhibitors. There's remdesivir, which also gets into the issue of administration in infusion centers. So I would say it's there, but not a lot of places are equipped to handle it, particularly with diversion of resources away from all hands on deck, clinic setup, and all of that stuff. And it becomes a competing risk for transplant clinics.
So thank you. That's great. So you mentioned Paxlovid. So very quickly, let me go around the room and say, are you using Paxlovid, or are you prescribing it to? So Bonnie, you want to start?
Yeah, sure. I still think that we're still recommending Paxlovid for higher risk groups. I wouldn't give it to everyone, but certainly people over 75, I would consider it for people over 60 for sure. And I think we know, and we've heard a lot from colleagues that in frontline populations, especially lower socioeconomic with higher risk for underlying conditions, I would even consider for people over 50 and over. Probably not for other age groups.
How about you, Paul?
Well, I was very disappointed by the EPIC SR trial, just based on talking to my patients and anecdotal impressions. I was under the impression that it shortened symptoms duration, and this just shows how people who are on treatment always report that their symptoms get better faster.
So for those people that are our audience who are not up to date on different trial results, just give us a one blurb on the EPIC HR study.
Yeah. EPIC HR was done in the pre-immunity stage,
Right.
in people who were not immunized and never had COVID before, and that study was a home run. I mean, basically, 80 to 90% reduction in hospitalization, and then a numeric reduction in deaths for Paxlovid versus placebo. And then a study called EPIC SR, which is basically a standard risk population or people who had been immunized with a primary endpoint of symptom clearance. That did not show symptom clearance was faster. It was sort of trends, but not really. And it's disappointing because obviously hospitalization rates now for COVID-19 are incredibly low. And you may have seen presented this summer was a study of another very promising SARS-CoV-2 protease inhibitor, Entecavir, which again in a very low risk population demonstrated a really good viral load reduction, but no faster reduction in symptoms. So, you know, if you're not going to reduce symptoms faster and you're not going to prevent the severe outcomes, what is the reason to give it still? I think the reason to give it still is, as was mentioned, in really higher risk people still give it. And the other reason to give it is it might, you know, some observational studies suggest it might reduce the incidence of long COVID. But again, the incidence of long COVID has dropped substantially from the beginning of the pandemic. So I think we have a ways to go with our antiviral therapy for COVID-19. I'm very optimistic that we can get there. But right now, with the current agent we have, it's kind of so-so. It's not as bad as my colleague put to me, where he said, after taking it, not getting better quickly, and then rebounding, he said, this stuff is crap. You know, he's a virologist. But I don't think it's that bad, but it's really not where we should be. And I think that I hope that there's continued investment in better treatments.
Yeah, I mean, I think you and I remember the early years of HIV. I still think Paxlovid is the AZT or the DDI of antiretroviral therapy, right? We will be getting better drugs in the future. Peter, how about you? When are you using Paxlovid?
Yeah, so I divided up into thinking as shoulds and coulds. So my should population is those who are older than 65, who've not received a vaccine in the last year. Those are essentially almost everybody I've seen in the hospital in the last few months. They could be rescued by Paxlovid. They haven't gotten, even those people who've not been vaccinated, they weren't given Paxlovid. We know from the VA study at St. Louis that about 10% of people who are eligible in that population actually were offered Paxlovid. So I think that's the should population. And then the could population is, you know, those who are older than 50, particularly if they have comorbidities, those who are older than 65, even if they've been vaccinated recently, it's a little bit, so, you know, it's more of a discussion. But I think we can't lose the benefit of the shoulds. And I think this discussion about Paxlovid really makes it an average statement, and it's not an average statement. It's one where some people benefit a lot more than other people.
So one last question about COVID, because this is a question I'm getting a lot, is do we mix and match? What do? We got mRNA vaccines, but now we have, you know, a protein-based vaccine from Novavax. I will personally disclose that I have been always vaccinated with mRNA vaccines, and I just got a COVID updated vaccine with the Novavax vaccine. But I want to hear what you guys are telling people about what to do.
Well, I mean, I'm telling people I've said what I've said all along, which is I don't think we don't have data to support one routine or the other. So in the interest of not confusing people too much, I just tell them, look, just do whatever you can do. If you're going to get the most important thing I could have told them at the time is get a vaccine, whatever's there, whatever you feel comfortable with. There is an argument to be made for a protein-based vaccine if you've already had an mRNA vaccine in the past, and it's great that Novavax is available. And so if people want to do that, I think it's great. And given this reactogenicity of the mRNAs, you know, people will be willing to do that. So I'm a little more flexible about letting people make their own decisions, because I don't want them to start going down the rabbit hole about really teasing apart. Well, I don't know about this vaccine or that. Let them. I want them to just get something in their arm.
Paul?
Well, I have to say I've taken care of some people who've had very severe reactions to mRNA vaccines. Those are not common, but they do happen. And for them, I am strongly recommending the Novavax vaccine, because although there's no direct comparisons, it does appear, just based on cross-study comparisons, that it has a lower incidence of severe side effects. Now, I would love there to be, just like we talked about a data gap before about a COVID vaccine versus placebo. Wouldn't it be wonderful if we had in the modern era where we're recommending vaccines, and all three of us are recommending vaccines for high-risk people? Wouldn't it be great if we had a comparative clinical trial of the available COVID vaccines in high-risk people? Presumably, almost all would have immunity before entering, and then they could be, primary endpoint could be hospitalization or death, or even an endpoint of infection during the course of the respiratory virus season. So lots of ideas for clinical trials. We don't have the resources to do them.
No, but I think a lot of interesting questions. I just point out there was and again, this is a study done by colleagues of mine at Emory, but I thought in Nature Medicine this past week, there was a really interesting study that they did looking at sort of asking the question, why does immunity wane so quickly after mRNA vaccines? And at least what they found, and what they're postulating in this study in Nature Medicine, is that after mRNA vaccination, SARS-CoV-2 specific plasma cells are not durably established in the bone marrow in the long-lived compartment. Now, we don't know if they occur after protein vaccination. I said to them, how about we do the same study now using Novavax? Because I think that would be really interesting, at least give us a hypothesis of why we see the waning of immunity after mRNA vaccines. But, interesting science, I think.
One challenge is that the Novavax vaccine is at least currently far less widely distributed in the United States. And if you're watching this from Canada, you can't get it at all, I don't think. So that's a potential problem.
I think there's a Novavax advocacy or fan club on social media. Before it was actually FDA approved, they were going after it. So it was at least people I mean, like what Bonnie was saying, as long as somebody is pro-vaccine, I'm like super psyched at this moment.
I couldn't agree with you more. So let's move on to our next vaccine preventable disease. Why are we still seeing pertussis? What's going on out there?
There's a lot of reasons. First of all, it's not just this is an area where vaccine hesitancy is a little bit of it, but it's really not about vaccine hesitancy. There's plenty of other reasons to worry about vaccine hesitancy. Part of the problem is pertussis is a complicated organism. There are many routes of pathology that the organism elaborates a number of toxins and stimulates a number of pathways of inflammation. So as you may or may not remember, in the 80s and 90s, there were 5 to 7 different antigens that were targeted for vaccines. And we've gotten better about really reducing the reactogenicity of some of those vaccines. Some of those were live whole cell virus vaccines, which were incredibly reactogenic. More recently, we have acellular vaccines that are much less reactogenic, but many argue that are also less immunogenic because of the complex nature of the epitopes that probably stimulate inflammation for pertussis. So the bottom line is, if you look at countries that never instituted a cellular vaccine, they seem to have better rates of reduced pertussis. In countries, well-resourced countries where we've been using a cellular because of the issue of reactogenicity, we do see still regular surges of pertussis. Part of that is due to the fact that the vaccine, even at its best, is about 70% effective. So we know that there's waning immunity, and there's also probably some degree of force of infection involved there. So if you have very close contacts, you're going to see whole families that are going to come down with disease. The third issue is, of course, diagnostics. Nobody really tests for pertussis, but it's probably, the definition right now of a case definition of pertussis, at least to start an investigation, is anybody with a cough that lasts longer than 2 weeks, because many times that's actually pertussis that goes undiagnosed. Now, for adults, it almost isn't a big deal, but it's a very big deal for children, especially those under 6 months of age. So we had a big outbreak of almost 50,000 cases in the US in 2012, to the point that California decided to institute, without FDA approval, to approve maternal vaccination for pertussis. And we saw how successful that was, to the point that the FDA then retroactively approved the use of maternal vaccination. And that has actually reduced the risk. Everything else has not worked, including cocooning and all these other efforts. So really, maternal vaccination has been the most effective for the young babies. Now, despite that, not everybody gets that maternal vaccine, and it needs to be given with every pregnancy, because it's very short-lived immunity because it's passive. And so we're probably seeing another surge. Now, it is nowhere near as bad as the 2012 outbreak, but we're still seeing, 5 times more cases right now in the US than we did a year ago. So we're probably going through a normal surge. That's coupled with the fact that people were masked, predominantly masked during the last few years. So it probably extended the period of quiescence, but we're going to see a surge now. And it really, again, does point out to the fact that these diseases are never going to be eradicated, and we need to keep vaccinating. But if you're a pediatrician, this is a scary disease. These kids can die or have chronic disease. And we're talking about kids in the hospital for months, if sometimes even a year or longer, because of the horrible respiratory disease that they can get.
Bonnie, what about, you talked about waning immunity in adults if you want to kind of reduce the transmission to kids. But I know that there's such heterogeneity in, when you get a tetanus booster, people usually get DT and not always getting DPT.
Yeah.
What if everybody just gave DPT to everybody who's going to get a tetanus booster?
Yeah, well, that's the idea, right? In the US, at least, in healthcare settings, you're supposed to get Tdap. And Tdap is, that is the general recommendation, is to try to get a Tdap. Now, it kind of just goes along for the ride. For most adults, it's not going to make it, they're not going to be aware, but it can hopefully reduce circulation. But again, to Paul's point, we just don't have data to understand what's going on.
There's a for those of us who practice hospital-based medicine, unfortunately, Tdap falls into that category of non-Medicare covered vaccines. Yeah. So you have to actually get it at a pharmacy. So when our older patients are due for their tetanus boosters, if you go to write a prescription for them to get in your clinic a Tdap, they may get charged for that. Whereas if they get it at a local pharmacy, they won't be charged. And this is, these kind of rules, they have nothing to do with what's good for patients. It's just sort of the agreement. So I am guilty periodically of doing the TD because it's recommended, the tetanus boost is recommended. And, unless they have little kids that they're seeing grandkids or something, then I don't bother with the pertussis part. But you're right. I mean, optimally, they should get Tdap especially when there's an outbreak.
It's interesting. We have already heard about lack of data, and I think all of us talk about, well, we need to practice evidence-based medicine, but a lot of times there's no evidence, right? And the reality is you practice the best medicine based on the evidence you have, and the evidence sometimes is very, very limited. And I think that's a reality that people don't necessarily realize every day when they walk into their doctor's office. Mm-hmm. So influenza, with COVID, you said, Bonnie, that there's no seasonality. I think there's seasonality in influenza. There is, in COVID, there's seasonality. It's the air conditioned season and the heating season, right? I mean, when people go inside for air conditioning, you get COVID outbreaks throughout the South. And those are the two peaks that we see almost now. We've seen it for the last 3 years, right? A summer and a kind of winter peaks, which is when people are indoors, hanging out together. But influenza, clearly there's a season and there's a seasonality. So right now we're worried about influenza. We see the antigens that have gone to the new influenza vaccine. It's a trivalent, not a quadrivalent vaccine. It's a trivalent vaccine. We're vaccinating people, but many of us are worried about the other flu, right? The H5N1 flu happening. So why don't we first talk about seasonal influenza and how are we approaching it and what are we doing about it? And how are you who are you talking to about vaccination?
Well, as Peter alluded to earlier, you know, the universal recommendation makes the most sense right now. It is clearly a pathogen that's going to affect all age groups, of course, differentially, but you know, the very young and the very old, we still see. Actually, interesting. You brought up the 200 COVID deaths. There's exactly 200 deaths from flu this year, this last season, and the season before. And before that, of course, we had COVID, so we had less flu. But it really is a disease. If you measure it an economic impact, it certainly has a huge economic impact across the age spectrum. I do worry a little bit about the, not a little, I worry a lot about the effectiveness data and the way that will come across to individuals. But again, I talk about the cup, or the glass. The glass is very large. So if we license a malaria vaccine that's 39% effective, then we should be supporting a flu vaccine that affects, you know, millions of people in our country. So I continue to recommend it. I know people still don't believe, you know, I got the vaccine, and still people come and say, I got the vaccine and then I got the flu from the vaccine, which is again a double negative. But we just have to keep messaging. And I think this message of respiratory season virus vaccines is really important.
Yeah, I would say that last year I got the vaccine and I got the flu A, not from the vaccine, but I got flu A. But I would say also that if I hadn't been vaccinated, instead of being home with the flu, I would have been in the hospital. I really think that the vaccine made a big difference in what I could potentially have as disease. I would tell you also my anecdotal experience of being the other day at CVS awaiting to be vaccinated for both flu and COVID is there were a lot of people there lining up to get their flu vaccine, but everybody when offered a COVID vaccine said no. And the data we have from last year is about 40% of the US population got their flu vaccine, but only about 8% got a COVID boost. So I do worry about that gap, and hopefully the COVID denialism and lack of interest in the vaccine is not going to drive down our influenza vaccination rate, because I think we really have gotten our vaccination rates to 40-45% of the population, which is not bad, quite frankly.
Not bad for adults, right? I mean,
No.
I think, you know, it's in our DNA, and it's in a pediatrics
I think it's the best
DNA, but
vaccine.
for adults, that's actually a pretty good. I mean, I think you're moving in the right direction.
Look at what happens to the other vaccines for adults. I mean, you know, shingles vaccine has a very low coverage. You know, HPV. I go around and just other adult vaccinations. We adult physicians are just not very good at this vaccination. So,
denial is a very strong motivator for adults. I think when you look at their children, I think their risk tolerance is much lower.
Yeah.
One vaccine. I hate to digress. Do you mind if I digress for a moment?
No, totally.
Okay. So herpes zoster is incredibly common in adults, and it becomes more common with each decade. And because we're infectious disease doctors, we tend to see the most severe cases, and it can be really devastating. It can sort of change a previously very healthy older person to becoming like a disabled chronic pain patient, which is really a horrible thing to see. And so of all the vaccines that we recommend in our outpatient practice, I have to admit, this is the one I recommend the most strongly. And I do so with the caveat that it is quite reactogenic. On the other hand, I do am able to look at a placebo-controlled trial of this adjuvanted zoster vaccine that we have and be able to say, look, this dramatically lowered the incidence of both zoster overall and severe zoster in particular. And so I can strongly recommend this. And then I say to them, do you know anyone who's had shingles? And they almost always say, yes, I do. And I said, and what did they think of that experience? You know, they don't like it. So I feel like, you know, I've put a lot of energy into the zoster vaccine.
Paul, I absolutely agree with you. You know, when we saw the data at ACIP, I was astounded. This is a miracle vaccine, and it's really works incredibly well for people 90 and over. How often can you say that?
Amazing.
And I have had both of my parents experience zoster, and I've seen, of course, we see patients. I see children with zoster, obviously, too. Not so much now, but it's a terrible disease. I personally was in bed sick for 2 days after the vaccine, thinking that it was all in my head, but it wasn't. No. But honestly, I would not have traded that for one bout of zoster. So, I think we need to really push that.
That's an advice I give people, right? Having received the vaccine as well and feeling pretty bad the day after. It's a Friday vaccine. You need a day off after you get the
All the
vaccine.
adjuvant. It's the same adjuvant as in, or related to the one in RSV. So that's why these vaccines are really good.
I mean, it's the adjuvant is Salmonella LPS. That's why you feel so bad.
Yeah.
So
I want to go back to something that because Paul digressed. The RSV vaccine I think it's again, another, I wouldn't say a miracle worker, but it's an amazing vaccine for people 75 and older, and probably for many 60, but implementation is really not good right now. It's expensive. Medicare is it's hard. The pharmacies are trying to dodge it. If you are under 75 and have a condition, trying to get that letter and get the vaccine from the pharmacies is really tough. And if you're an older person or you don't have transportation, I just think uptake is going to be really hard unless we make it easier for our older population to get that vaccine.
So I'm gonna move you a little bit and we talked about elderly populations, we talked about young children, but we haven't talked about a population that I think is really important when we talk about these 3 vaccines, which is pregnant women. Mm-hmm. So pregnant women, and maybe we can start with the data on influenza and then talk about COVID, but I think in RSV, there's some really interesting recommendations from the ACIP that I would love, Bonnie, for you to sort of walk us through it. So Peter, what are you telling pregnant persons?
Oh, definitely between the weeks of 32 to 36 weeks, so 3rd trimester, definitely get the vaccine if at all possible. I had this interesting question from a patient who was going to do it, but then she had to have an emergency C-section. So it's important to kind of put your ID hat on too and think that if you just got it just before the C-section, it's not going to do the job what you're supposed to do, which is to have antibodies cross the placenta. So, in that case, you give the kid under, 9 months the vaccine. But in general, during RSV season, 32 to 36 weeks, it's a no-brainer for me. All of that morbidity being avoided. We know that at 6 months and 12 months, not only do kids have a higher chance of doing better after birth, but interestingly, at least that's around 70%, but 50% fewer clinic visits, which again would make the health economics people happy.
So RSV.
So let me just say for pregnant women, the data was, unfortunately, the FDA had a tough choice to make, right? The vaccine works incredibly well to protect babies at least through 6 months of age, potentially longer. And that is absolutely the highest risk time for those babies. 2% of all babies in the United States are hospitalized for RSV, the most common cause of hospitalization for kids in the United States. This vaccine has an opportunity to really reduce that. And unfortunately, there was a non-statistical signal for potentially preterm birth in women, primarily before a 32 weeks gestation. So FDA really, really thought about this, and they licensed it for 32 to 36 weeks because they wanted to follow up on data. Now, of course, because you can't give it to people under 32 weeks, you're not going to be able to resolve it based on new data unless somebody accidentally gets it before 32 weeks. But the data, follow-up data was published showing that the preterm issue was really not statistically different from the placebo group. And the vaccine in pregnant women uptake was about, I would say about 15% or so, less than 15% last year, but it was a license in September. So, August, and then CDC approved it in September. So we didn't have much time. Surprisingly, almost 60% of all babies were protected either by maternal vaccine or nirsevimab, which is pretty remarkable when you think about the fact that these were just licensed a month before RSV season. And so the effectiveness data look pretty good. I think, Carlos, you and I saw some of that from CDC last month, but I think more data will be coming out. This could really be a game changer for helping these babies. And then the next step will be, there are vaccines that are going to be studied for the 2-year-olds, because even though the highest risk for severe disease in the babies, we know from a couple seasons ago that when RSV was not transmitted because of COVID precautions, the kids who got the sickest were not only the little babies, but the 3 and 4-year-olds as well. So naive 2 to 3-year-olds are also going to be probably at risk. And there may be there are vaccine trials that are going to be started soon for 2 to 4-year-olds.
Good. Well, let me just let's answer some of the questions we have in the chat, because there's some interesting questions here. There's some comments from people saying, well, decreasing the viral load seems like a good idea around Paxlovid. Hopefully, it would decrease long COVID too. Yeah, I mean, I think we have the data still limited on that, right?
So Carlos, one thing that we didn't talk about around viral load, because we've all looked at it. I mean, we started doing this from the very beginning when we did all our trials in the 2020 era. And viral load, you would think, would make a difference in terms of household transmission. It really hasn't panned out that way. And I'm not quite sure if we just haven't done a good job of studying it, or if it really truly isn't a factor in transmission. So if anything, one of the thoughts could be, well, increased viral load means more super spreaders. And that hasn't really panned out yet, although I don't know that the data is perfect.
I think the only data that I've seen is increased viral load associated with more severe disease.
Yeah, yeah.
I mean, it is possible also. So much of the first phase of the pandemic were people diagnosed relatively late after viral transmission probably occurred. That's less common now because of the dynamics. The viral dynamics are different now than they were in the pre-immunity phase. So I wouldn't be surprised if ultimately viral load reduction does reduce household transmission, but we just haven't, as you mentioned, we just haven't proven it yet.
Right.
So Richard,
well, the other thing, just to mention briefly, also the new variants also target different receptors. So if you're really targeting more upper respiratory rather than lower respiratory, is that going to lead to more risk for, again, reduced transmission if you target those newer variants? And that data is probably not going to be available to us.
So our friend and Richard Halbrick is asking, what would you recommend for patients with autoimmune reactions after an mRNA vaccine? Well, I would say that we're going with Novavax, right? I would
Protein.
Yeah. And
I mean, that one's a no-brainer.
And then the next question that comes up is myocarditis and pericarditis following Novavax vaccination an issue? I
mean, can I say one comment with the myocarditis, pericarditis stuff? I mean, I was always intrigued that the risk was highest after the second shot in the 1-2 punch. So I wonder if it's really the sort of like the vaccine exposure that close together, and maybe it's different, spaced around. But you certainly do see a risk with Novavax as well if you look at the data.
But I think the other issue that I remind people is still the risk of pericarditis, myocarditis after vaccination is still lower than the risk of myocarditis, pericarditis from getting infected. Yeah. Not that the vaccine necessarily decreases your risk of infection significantly, but there is a difference there, right?
Yeah, absolutely.
So what do you guys see as the concerns? Where do you see this H5N1 outbreak going, and what have we learned, if anything, from this outbreak?
Well, I think we had the first 2 cases in humans in California from dairy cows yesterday announced. Both had conjunctivitis, pink eye. It's not clear possibly, but they apparently were wearing PPE, although who would wear that with these heat waves in California? And they were likely splashed. One of them got Tamiflu. There've been, I think, about 9 cases, I think. Six, for this year so far from dairy cows. I think the big issue for me is that we're just looking at the numerator, and we're not controlling the outbreak in cows or cattle. We don't even know how we're doing, because it's voluntary whether or not companies or farms opt in. It's an opt-in system to have surveillance. So except in, like, I think Michigan. So I think where there's a pilot program from the CDC. So I think that's the main issue. One of the main issues is just like running around with Vaseline on eyes.
Well, the other thing I've learned a lot is I'm learning a lot about the fact, something I didn't know is how cows are moved across the U.S. and across.
Well, we learned that from E. coli OV157H7. We learned that that network of cattle is very hard to penetrate. I mean, our friend Lee Riley was really late friend and dear friend Lear Riley was one of the people who really helped us understand that cows in one state, one hamburger patty can contain meat from 10,000 cows from all over the country. If you want to, if you want to talk about mixing and matching, boy, that's really it. I really think the
But
issue.
the other issue is that cows may be born in Minnesota, but then they go like,
Right.
like New
They're here
Yorkers,
on Highway 5 at
they go
Petaluma
south for
City,
the
where all
winter and
the
then they
cows
come
go
back
to
up
die.
north.
Yeah.
And
Yeah.
people and machinery go across state
Yeah.
lines, so it doesn't matter if the cows don't.
So
But
one
to
of the one of the
people-
things I learned, Carlos, from this whole situation is more, of course, the details are important, but I'm looking at the systemic issue here of how do we deal with an impending problem of huge import. It's almost like watching a slow moving car accident. I'm not saying we're going to get there, but we could. Where are the studies? Why are we not thinking more carefully about vaccines for cows, for chickens? We know that there are vaccines for rotavirus, for all kinds of animals, because it's important to the agriculture industry. It should be important to them to think about this. This is like schools and masking in the sense that you have one school district, you have one school district. It's the same with this whole cattle industry. We're not looking at it systemically. We should be building better diagnostics, better ways to distinguish vaccine-related immunity from natural immunity, because that's the concern, is how can you sell your cow to the European Union if you're antibody positive? They won't accept it. Well, we can fix that problem. We know how to make diagnostics that can distinguish between vaccine and natural immunity. These are all fixable problems. We just have not come together, bringing, say, USDA, business interests, and virologists. I mean, these are not hard questions. We have vaccines already for people. We could make vaccines for birds and cows. And more importantly, we could avert eventual evolution of this virus, if it happens, into something that will infect people much more easily than what we're seeing now. And in that case, if it happens, we're sunk. It's really frightening to see what we're not doing about H5. And this is just the canary in the coal mine.
So Paul, this is totally asking your opinion, I know, but it's interesting to see H5N1. We all learn, at least cases from Asia, high mortality.
Yeah.
Yet what we're seeing among our farm workers is primarily a very mild disease, right, with conjunctivitis and not much else. So what do you think is going on?
I think that the identification of the animal cases has led to increased surveillance among people who work in the domestic cattle industry, and that has allowed us to see a broader range of cases than were initially reported, which are, of course, only the severe cases. It sort of reminds me of, in some strange way, but you'll get the epidemiologic analogy of when West Nile first appeared in the United States in the early 2000s. Initially, it was like, gosh, there's all these cases of encephalitis, and then when they did serosurveys in communities that were kind of hard hit with these encephalitis cases, they found actually it was just a tiny fraction of the cases were symptomatic, and that most
the spectrum of disease is very broad, right?
Very broad, and
Yep.
I am, I'm hopeful that in this scary scenario that Bonnie just outlined, which is very plausible and potentially very scary, that we do learn that this is not as lethal universally as we had thought in the first reports.
And my understanding, if correct me if I'm wrong, is that at least from the isolates we have so far, they remain sensitive to the currently available antivirals, right?
Yeah, they are so far. Yeah.
So, last sort of again, speculation. What do you think is going to happen with this outbreak? Do you think we're going to see more human-to-human transmission? It's going to kind of die? What do you think? What do the crystal ball tells us?
No, it's definitely not going to die.
It's going to keep
The
going.
train already left the station. It's already a pandemic in birds, and it's crossing over to mammals. So
Oh,
actually, it's
remember
not.
all the seals that died in South America, right?
And we don't
And the
cover
cats,
seals a
the
lot. I
cats who
think that's
drank
why.
infected milk.
I mean, poultry and cows, we humans are in touch with them all the time. So it's just, and more transmission events you have, the more likely there is going to be some reassortment or mutation. So I think, that's what I would think of it as medium term, maybe not in the next year or two, but eventually.
If it turns out to be a fundamentally different virulence from current influenza, that would be particularly scary because I think inevitably, as Peter and Bonnie both said, this is here to stay. We're not going to eradicate this reservoir. But if it is more pathogenic, we're only going to know that really by doing more accurate testing and doing the kind of molecular testing that we really advanced a lot during COVID-19. I always trying to look at, silver linings of things that got better during the pandemic. And one of them was respiratory virus testing, much, much more broadly available. And
home testing, right? I mean, the idea that you can have home testing is still pretty incredible. Right?
Yeah, but yes, exactly. But I would like to see some way, as alluded to by Bonnie earlier, for us to be able to tell when we diagnose someone with flu, is this a circulating strain that's common, or is this potentially H5N1? And that right now is not the information we get. We just get influenza A or B.
Yeah, well, what CDC will tell us is some of those strains of influenza A, then go to the state lab and go to CDC. So 6 months later, you'll know.
Well, there is a case now in Missouri where the CDC is investigating. It hasn't been reported yet, but a patient in the hospital came in with non-respiratory.
Right. But that's been weeks and we still don't know. It's amazing.
Well, they confirmed it now. That's
right. But I'm just saying it took forever. Yeah. Now, here's the thing, though. We know that there's flu surveillance. We have polio surveillance labs in 149 countries around the world. You can diagnose polio in a week in, the middle of Afghanistan or Pakistan. We have the tools. We have I'm just saying from a systemic standpoint, what did we learn from the pandemic? We need to understand how to build our surveillance systems and as you alluded to, Paul and Peter, where is the data that we should be able to pull these data together? Surveillance is not, we have the capacity to do surveillance for this pathogen and others, and just put them all in context so we know what we're dealing with, so we don't get blindsided. And I just think in general, not just for H5, but whatever else comes down the pike, we could have a really nice coordinated global system that's not going to be that expensive. These tests are not hard to do. Yeah,
absolutely. So let's move on to the last virus du jour. That's Marburg, right? That's another ongoing outbreak in Rwanda that is spreading into neighboring, it's causing a significant mortality so far. And so what do we need to do? What are we monitoring? What are we worried about? What are we telling?
I don't think we really know yet. I mean, I think CDC has a web page where they're talking a little bit about it. They just updated it recently. I think you and I, Carlos, have been on the phone with people on the ground. Some of our fellows were just there. So there's maybe, as far as I understand it, confirmed 27 cases. Now, it may not sound like a lot of cases, but think about this. This is like Ebola in every single respect in terms of morbidity, mortality, except we don't have a vaccine and we don't have any antiviral therapy for it. And it's just as contagious. Now, 27 cases in context is the largest number of cases ever reported of Marburg. And it is from many provinces, not just one area of Rwanda. And Rwanda has an incredibly good healthcare system. So to your point, Paul, they're very good at doing surveillance and they pick them up really rapidly. But even now, and these are all in healthcare workers. So which is, as Carlos pointed out earlier, it's not what we would expect because those are the people that are going to be exposed to the cases. So I think we just need to keep an eye on it. But it would be really helpful for us in the, when we're sending people out to do, research, teaching, whatever, they just need to understand that there's a risk in Rwanda. I think they're going to be able to contain it well because they have a good infrastructure. But it is, again, just a reminder that when we travel, we need to be aware of the risks that are going on, like mpox in DR Congo right now as well.
The other point about Rwanda, Bonnie, and correct me if I'm wrong, is that this is the first time it's been seen in Rwanda.
Yeah.
So I think it just reminds me of all these other emerging infections where it just starts off geographically limited, but then it metastasizes.
So we're all like, have patients, have relatives, have colleagues, and we're communicators and trusted messengers. So if somebody calls you and says, hey, my family's planning a trip to Rwanda this winter, we're going to go see the gorillas, what are you telling them?
I think they can go. I think they need to be careful around, I would stay away from, if people are sick, febrile people. Now the incubation period is 21 days. So obviously they might not be sick right away, but again, it's primarily been focused on hospitals and healthcare workers. So I would just be really careful when you're going to a region to check on the local epidemiology. Again, they have a very good notification system. I wouldn't stop people from going. We haven't sent our trainees there yet because we're working in hospitals, and I don't know that we don't have the same oversight of our trainees outside that we would here. And, there may be spot cases within the different hospitals that people are working in.
Yeah, to me, that's an important message, right? Most of the cases, and in fact, all the cases have been in healthcare facilities. It infects pretty much like Ebola does, primarily in healthcare. So if you're going to go see the gorillas, you probably are fine. If you're going to go to a hospital to work as, a missionary or some global health experience, that would be a different situation.
Next summer's International AIDS meeting is in Rwanda.
Yep.
Be interesting
Oh yeah,
to
I'd
see.
forgotten about that. That's a good point.
I think they'll be okay by then. So, and then again, you just want to bring up the mpox issue because mpox, it's not the clade 2B that we saw in 2022. This is the clade 1B and 1A to a certain extent. To over 27,000 cases in DR Congo with 1,300 deaths, mostly in kids, and now spreading to the central to 14 other countries in Central Africa. I was just in Zimbabwe, and they haven't seen cases yet, but they're really worried because we don't really understand how it's spreading yet at this point. But it's seems to be some bushmeat, but mostly person to person. But the data are pretty sparse because those are countries that don't really have the same surveillance and public health capacity as, say, a country like Rwanda. So that's the outbreak that I'm a little more worried about in terms of local transmission. And even may have already gotten to Europe.
The WHO did approve its first point of care testing, I think, in the last day or so, which is exciting. And I wish we can have it here in the US.
Yeah. And they're getting vaccine now, but building the infrastructure to give those 10 million doses that they need is maybe not quite there yet. But I think they're going to start working. Hopefully they'll start getting some more support.
I think that this really emphasizes the importance that we have of thinking, you may think locally when you think about diseases, but you got to think globally when you think about pandemics and outbreaks, right? And an outbreak in Rwanda should be of concern to all of us in the infectious disease community globally. And I think this, unfortunately, this global thinking is something that many people in the United States still don't realize how important it is. They say, well, let's worry about my community. But in order to worry about your community, you also have to worry about the global community.
It is quite remarkable, since I want to always show at least the glass half full story, how the 2022 outbreak in the United States was eventually contained. Now, it's not gone, but wow, that summer we were seeing cases regularly, predominantly in men who have sex with men, but boy, it was taking us a huge amount of time to navigate these new cases of a disease none of us had seen before. And now we see a case every couple of weeks, if that, and it's really changed. And plus, we're very lucky we have the availability here in the United States.
We were incredibly lucky that we had the Jynneos vaccine.
Yeah.
I mean,
Well, I think it's a combination of things. Yes, we were lucky we had the vaccine. But I think really, and I'll give a lot of credit to Dimitri Daskalakis, who used lessons from HIV to really bring community into the picture very early on, right? And the combination of industry, investigators, like many of us in community, brought together and, community changed behaviors. We got vaccinations. And I think those combinations really brought cases down in a way that, quite frankly, was a total success.
Yeah. Tecovirimat is, we still have an ongoing study that's in the United States, and now we'll see whether there's a second negative study, because if so, that would be kind of probably the end of that drug. Yeah,
but I'm glad we're doing the study because again,
absolutely,
and that's why we need clinical trials, and clinical trials are critically important. And I think the STUMP study hopefully will finish enrolling and will give us some answers.
I actually totally agree. I'm very glad we're doing that study.
Well, last minute, final comments, Bonnie.
I'm really, I'm just really grateful that we have the science and the technology to be able to build a lot of these preventive efforts, because a lot of what we talk about are prevention. Obviously, treatment is important. We still need to do a better job with antivirals, but at least the investigation on both prevention and treatment are moving forward. I think we still need to do a little better work. I mean, we saw the success with mpox, as you saw from 2022, around surveillance, but let's keep going. We need to keep building our surveillance structures, not only in the US, but elsewhere.
Paul?
Those are good concluding remarks. I'm going to put in a pitch for better COVID-19 therapies, because there's obviously still lots of ongoing misery from COVID-19, even if it's not causing the same rate of hospitalization and death.
Yeah, we need more research into antivirals against respiratory infections. Peter?
I think one of the biggest threats that we have is misinformation, disinformation. So I think we, as clinicians, need to really acknowledge that and address that, and continue to have conversations with our patients and our community.
Yeah, and I would just end by saying, continue promoting vaccination, encouraging your patients to get vaccinated, and let's hope increase the rates of vaccinations to community, because it's all about that community level protection that makes a big difference. I want to thank the three of you for joining us today. This has been a fantastic discussion, and thank you very much.
Thank you for listening to this episode of Going Antiviral. Catch up on earlier episodes wherever you listen to podcasts, and check out the video versions of this episode and others on the IAS-USA YouTube channel. You can find these links in the show notes, or simply go to YouTube and search for IAS-USA, and there they are. Be sure to subscribe, rate, and review Going Antiviral on Apple Podcasts. This podcast is for informational and educational purposes only and is not intended to serve as medical advice. Opinions expressed in this podcast do not necessarily reflect the opinions of the IAS-USA or its affiliates. If you have a question you'd like answered on the show, you can send it to podcast@iasusa.org to be answered in a future episode.